Good afternoon, everybody. Welcome to today's live lecture where we will be discussing the disorders of the lower gastrointestinal system. We'll also be going over how the disease starts, what are the causes of the disease, how do you treat the disease, what are the signs and symptoms, what are the things we need to monitor for as nurses, and what we should educate the patient on upon discharge. So let's not waste no time and let's get right into some of the disease processes. First disease that we'll be talking about, well, I wouldn't say disease, it's more of a symptom or like a syndrome or just an infection or just something that may be going on with the body. This is diarrhea and constipation. Diarrhea, as I'm sure we have all know, diarrhea is a frequent loose or watery stool. It can result from an illness, dietary changes, infections, or medical conditions. And then we have constipation, which I'm sure everybody has, like diarrhea, has had a form of constipation at some point in your life. Constipation is an infrequent, difficult stool passage. This is caused by a lack of fluid intake, immobility, which is not moving around and laying around in bed, medication side effects, and underlying serious conditions. Some treatment and nursing management for diarrhea and constipation includes a general health assessment. Some medications would include bulk forming agents, some stool softeners like Metamucil. Some dietary recommendations would include to increase fiber intake, avoid gas forming foods such as legumes, the cabbage family, onions, potatoes, restrict milk for lactose intolerant patients. And some things you're going to want to educate the patient on is to wear loose clothing if bloating is present. And instruction on medication adherence and dietary therapy. All of these things will be important in order to help deal with constipation and help manage diarrhea. Some medications for diarrhea. So some common drugs include some diphenoxylate hydrochloride, which is Lotimil, some loperamide, which is Idiom, some choline pectin combinations. Please excuse the way I'm pronouncing some of these medications because medications in their generic form are very difficult to read. Some actions would include to decrease fluid content, to bind water, and to coat the mucosa of the stomach. And some things that you are going to want to teach the patient is to not exceed recommended dosages of these medications. Some Pepto-Bismol can also cause black stool. So if you're taking Pepto-Bismol for diarrhea, it can cause black stool. So don't be too alarmed if you see that. Some medications to help with constipation would also include some bulk forming laxatives such as Metamucil, which is penicillium, and methacellulose, which is Citracel, which acts like a fiber which absorbs water in the bowel to enhance bowel movement. You're also going to want to take some surfactants, which this includes some docusate sodium, which is Colace. And then the action of docusate sodium is to facilitate water absorption in the stool. You're going to want to teach the patient to take with a full glass of water and not to use for a long term without the provider's knowledge. All of these things are going to be very important for medications for constipation. Contact laxatives. This is another medication that can be used for constipation. This includes your Bisacodral, which is your Docalax. This includes your Senna, which is Senecot, and your Cascara sagrada, which is a herb that is commonly used as well to help with constipation. The actions of these drugs include to increase the secretion of fluid and electrolytes in the intestines. Some things that you're going to want to teach the patient. You're going to want to teach the patient that tablets should not be chewed. Swallow your tablets whole when you take them with water. Take with a full glass of water in order to help with the absorption of the medication. Some side effects for the laxative include burning rectal sensation if the suppository is included, and colored urine, which could be pink or a brownish yellow color. Next, we have IBS, which is irritable bowel syndrome. So what is irritable bowel syndrome? This is pretty much your group that includes the constipation and your diarrhea, characterized by abdominal pain, bloating, or the absence of a detectable disease. The diagnosis for IBS includes, based on clinical manifestations, ruling out organic bowel disease. Some symptoms would include abdominal pain relieved by defecation, changes in stool frequency and consistency, and mucoria, which is mucus in the stool or bloating. The definition of the irritable bowel syndrome would be a functional GI motility disorder. That's pretty much what IBS is. It's a functional GI motility disorder. It's prevalent mostly in women and a major reason for missed work days in North America. Some of the causes include a familial predisposition, stress, caffeine, sensitivity to dairy or wheat. For the pathophysiology, it includes an altered motility of small and large intestines, possibly triggered by infection, stress, or altered nerve function. So irritable bowel syndrome pretty much just includes your diarrhea and your constipation. Some treatment would include a symptomatic relief, peppermint oil for temporary pain relief, and avoid peppermint oil and GERD in patients. We're going to talk a little bit about GERD a little bit later. For nursing care, teach your patients about lifestyle changes, diet management, and stress reduction. Some medications to treat IBS would include your linaclotide, which is Linzess, and lubiprostone, which is Amitiza. I'm not too familiar with either one of those drugs. I will definitely look them up after I'm done this presentation. The actions of these drugs include to increase fluid in the intestines, reduce pain sensitivity. Some nursing considerations would include to warn against direct sunlight exposure due to photosensitivity. Patients may experience side effects including nausea, abdominal pain, diarrhea. For patient education, you would want to take these drugs on an empty stomach and report adverse effects such as shortness of breath. Very important, you want to report those things to your provider. Next, we have diverticulosis and diverticulitis. The definition of diverticulosis is a presence of a diverticula in the colon, which can be an asymptomatic situation. For diverticulitis, this is inflammation or an infection of the diverticula. Some risk factors include a low fiber diet, obesity, constipation, and aging. Some signs and symptoms, diagnoses, and treatments for diverticulitis includes lower left abdominal pain, one of the major signs of diverticulitis, lower left abdominal pain, bloating, nausea, vomiting, diarrhea, or constipation. See, when you know where things are, lower left quadrant, this is your diverticulitis, and lower right quadrant, which would be your appendix, which we'll talk about a little bit later. Some diagnoses include a CT scan with contrast. This is the preferred method. You would want to avoid a colonoscopy during acute cases. For treatment includes clear liquids, organ antibiotics, high fiber diet after recovery, and for severe cases, IV antibiotics and bowel resting. A diet for diverticular disease would include a high fiber diet, which all of these things that include high fiber is whole grains, cereal, breads, your fruits such as some apples, berries, peaches, and pears, your vegetables such as squash, broccoli, cabbage, spinach, the legume family such as the beans, the peas, the lentils, and drink plenty of fluids in order to aid with your digestion, because more fluids is going to help move your bowels past a lot easier. Some lifestyle changes include to incorporate regular exercise in order to prevent constipation. For intestinal obstruction, the definition of this disorder is a blockage by preventing normal passage of contents through the intestines. The types of intestinal obstruction include a mechanical and a non-mechanical. For the mechanical intestinal obstruction, this includes tumors, adhesions, volvulus, and hernias. For non-mechanical, This includes a paralytic ileus after surgery, hypokalemia, and in older adults, higher risk for volvulus due to a decreased muscle tone. Signs and symptoms. Signs and symptoms include, for the upper tract, sharp abdominal pain, vomiting, minimal distension. For the lower tract, this includes a gradual onset severe distension, fecal vomiting. For treatment for intestinal obstruction includes a decompression with an NG tube. Surgery is also needed for unresolved cases. And you also want to monitor the fluid and electrolyte balance, pain management, and monitor their abdominal girth. Hernias. So a hernia is a protrusion of the intestine through the abdominal wall. Types of hernias include ventral, which is an epigastric and an umbilical, and an inguinal and a femoral. Okay, so 3 types. Ventral including the epigastric and the umbilical, and the inguinal and the femoral. Some symptoms for hernias include a swelling or a lump in the abdomen / groin area, discomfort, or pain. For treatment, herniotherapy, surgical repair, herniorrhaphy, which is a surgical repair, and a laparoscopic or an open surgery with a mesh reinforcement. For nursing care for hernia repair, for post-operative care, monitor pain control because the person may be in pain after having this hernia removed. Avoid heavy lifting or activities that increase intra-abdominal pressure. As we know, lifting or increased pressure can increase the risk for hernias. Teach your patient to support the site when coughing or sneezing so that they don't push the hernia back out or add any more extra pressure to the abdomen. And you're going to want to monitor for signs of complications such as infection or a recurrence of a hernia. Moving along, next we have bowel ischemia. The definition of bowel ischemia is when bowel ischemia occurs when the blood supply in the intestines is insufficient. The causes of bowel ischemia include low blood flow, which is hypovolemia, which can lead to shock, and a gradual narrowing / occlusion of the vessels. Diffuse atherosclerotic disease of mesenteric vessels. Very difficult words. Acute versus chronic. This can be an acute or chronic condition depending on the duration of the onset of symptoms. Signs and symptoms and diagnosis. This includes a sudden severe abdominal pain, nausea, vomiting, diarrhea, abdominal cramps, tender abdomen, guarding your abdomen, and a minimum or absent of bowel sounds when you auscultate the abdomen. Diagnosis includes elevated white blood cell counts. When you get your CBC and they check the numbers of your white blood cells, if the white blood cell count is elevated, this is a sign of bowel ischemia. A CT scan or angiography or magnetic resonance angiography, MRI pretty much. CT scans or MRIs is pretty much how they're going to diagnose the bowel ischemias. For treatment, make sure this patient is NPO, nothing by mouth. They will need an NG tube, which will relieve distension. Hydration, which would include some IV fluids, and monitor the output of the urine. Some medications would include an IV heparin and a thrombolytic therapy. Surgery may be required if the bowel tissue is necrotic. So if you let that tissue die, then surgery for bowel ischemia may be needed. Next, we have inflammatory bowel disease, which is different from irritable bowel syndrome. So, inflammatory bowel disease includes ulcerative colitis and Crohn's disease. Ulcerative colitis, also known as UC, and Crohn's disease. Those are the 2 actual inflammatory bowel diseases, not inflammatory bowel syndromes. Different. The syndromes were the diarrhea and the constipation, while your diseases is the ulcerative colitis and the Crohn's disease. These are genetic predispositions, and more common amongst the Jewish population. Smoking increases the risk for Crohn's disease, but not for ulcerative colitis. Signs and symptoms. This includes a diarrhea, which is often bloody, abdominal cramping, and weight loss. More bloody stools in ulcerative colitis, and a fever in malaise and cramping. Diagnosis includes a colonoscopy, flexible sigmoidoscopy, and a barial enema and a stool analysis. Treatment for irritable bowel disease. Diet. You're going to want them on a low-fat diet, a low-fiber diet, high protein, and small, frequent meals. Medications would include antidiarrheals, sulfasalazines, biologic agents, immunosuppressants such as methotrexate, and azathioprine. Surgical options include an ileostomy, a cock pouch, and an ileoanal anastomosis for UC. So drugs for IBD, these would include your sulfasalazines, your mesalamines, osalazine, balsalazide, the disododium. The actions of these drugs reduces the inflammation by suppressing prostaglandin synthesis. Some nursing implications include regular blood cell counts needed due to the risk of agranulocytosis and anemia. You want to teach the patient to caution with sunlight and use a non-oral contraception. Report rash or sensitivity. Infliximab, okay, so the classification of this is a monoclonal antibody. It neutralizes and to reduce the inflammation in Crohn's disease. It decreases the inflammatory cell infiltration. For nursing implications, you'd want to administer an IV over 2 hours, repeating dosing at 2 weeks and then every 8 weeks. You want to monitor for an anaphylactic reaction. Initial side effects include an increased diarrhea, and patients should report nausea, vomiting, or rash. It is very important to not breastfeed during this therapy. Antispasmodic medications. The common drugs include your dicloclamine hydrochloride, which is your Bentel, and all of these other listed meds that y'all can see that they are very long names that I'm not about to say here and continuously keep trying to pronounce. The actions of these antispasmodic medications is to block acetylcholines to reduce smooth muscle spasm and motility. It also inhibits gastric acid secretion. You want to teach your patient to take 30 to 60 minutes before meals. Drink 2,500 to 3,000 milliliters of fluid daily. It may cause a dry mouth. This is why you want to drink all these fluids. May make you dizzy or may make you have blurred vision. You want to report rash or skin eruptions to your provider because this could indicate an adverse reaction and they may need to switch some things up. These are pretty much some of the main differences between ulcerative colitis and Crohn's disease. So with UC, the mucosa is the only part infected. With Crohn's disease, you have full thickness in the intestine, which is usually the small intestine. So for UC, it always involves the rectum. And like I said, for Crohn's disease, it's mostly the small intestine. For UC, diarrhea with blood. For Crohn's disease, intermittent diarrhea with cramping, no blood. Some complications include a hemorrhage and cancer for UC. For Crohn's disease, complications include fistulas and obstructions. I just find it crazy how UC could possibly lead to hemorrhage and cancer, and Crohn's disease just leaves you with fistulas and obstructions. Both diseases are still irritable to the bowel and to the stomach, but one can lead to cancer and one doesn't. One contains blood in the stool, one doesn't. One affects the whole rectum, one is only the small intestine. So when you're thinking about ulcerative colitis and Crohn's disease, these are some of the main differences that you can use to differentiate between the two diseases. Appendicitis. Now, let's talk about the appendix. Appendicitis, this is an inflammation of the appendix. This is caused by a bacterial infection due to the obstruction of the appendix. This happens when you have trapped fecal material left inside the appendix. Some signs and diagnoses. This includes pain at the McBurney's point, which is at the lower right quadrant of the abdomen, right here. Also includes nausea, vomiting, muscle guarding, fever, elevated white blood cell counts. It is diagnosed by a CT scan or an ultrasound for pregnant women and children. For treatment, you may have a surgical removal of an appendectomy, and that's just pretty much taking the entire appendix out. For pre-operative, before this procedure, you want to put the patient on NPO, nothing by mouth, IV fluids, and antibiotics. For post-operative care, pain. The patient may be in a lot of pain, so you're going to want a pain management. It could be some type of pain medication or just whatever you can do to help the patient not be in so much pain. You also want to monitor for infections. Don't need any infections after surgery. And you also want to monitor for mobility. If we can get the patient up, moving as fast as possible, we won't have them immobile, which could lead to a list of other complications, constipation being one of them. For a safety alert, do not use heat for abdominal pain. You don't want to use heat for an abdominal pain for the appendix because this could cause the vessels to dilate and bring more blood to the appendix. And if you are bringing more blood to the appendix, that's going to irritate it more and possibly cause it to rupture a lot faster. So, no heat. If anything, cold, but definitely no heat. Nursing diagnosis and management for this. Like I said, monitor the pain due to inflammation, fluid deficit due to diarrhea, and altered nutrition from the diarrhea because you're flushing out all of your electrolytes and flushing out all of your, the things that your body needs, and you're having a malabsorption issue because you're flushing everything out with the diarrhea. For nursing goals, we are going to want to control the pain, restore fluid balance, improve nutrition, monitor stools, check for internal bleeding, and assess electrolytes. All of the things we are going to want to monitor for appendicitis. Next, we have peritonitis. Peritonitis, that's how you say that word. What is peritonitis? It's an inflammation of the peritoneum, often due to the rupture of an organ. Common causes include a ruptured appendix, a perforated ulcer, a traumatic injury to the colon, spleen, or liver, and a peritoneal dialysis. So pretty much peritonitis is caused by other things going on with the body that can lead to this condition. So for peritonitis, causes include pretty much for peritonitis, inflammation causes redness, swelling, and the production of purulent fluid. Bacteria multiplies, leading to infection, and a paralytic ileus may occur due to ceased peristalsis. Signs and symptoms. This includes severe abdominal pain, distension, nausea, vomiting, fever, chills, tachycardia, and shock if left untreated. For treatment and diagnosis, so to diagnose peritonitis, clinical signs include imaging tests and lab work. For treatment, you are going to administer broad spectrum antibiotics, surgery to repair ruptured organs, and drainage of the peritoneal cavity if needed. Nursing management, frequent assessments, monitoring for shock, pain management and infection control, semi-Fowler's position to assist breathing and localize infection. All important if the person has some type of surgery for the peritonitis. Malabsorption. This is pretty much when you are failing to properly absorb the nutrition in your intestines. This could be caused by celiac disease, which is a gluten intolerance, lactose intolerance, and pancreatic enzyme deficiencies. So Pretty much if you are not absorbing all of the things that you are eating, your electrolytes and all of your vitamins, this could lead to malabsorption. Some signs and symptoms include steatorrhea, which is a bulky, frothy, foul-smelling stool. That's that real big stool that goes into the toilet. And if you ever seen those real big stools, that's what a steatorrhea is. Weight loss and weakness. All of these things indicate that you are under some type of malnutrition or malabsorption because your body is not intaking all of the electrolytes and vitamins and all of the different proteins and things that it needs. And it's just coming right out in that form of the steatorrhea. Vitamin deficiencies is another sign and symptom, depending on the nutrient absorption issues. For diagnosis, you have a history of antibody assays, a GI series, and a biopsy. For treatment, you want celiac. To treat the celiac disease, you want a gluten-free diet. For lactose intolerance, you want lactase enzyme supplements. And for the pancreatic insufficiency, you want enzyme replacement therapy. Some cultural considerations to consider with malabsorption. Lactose intolerance. This is common in Native Americans, African Americans, Hispanics, and high amongst the Asian population. And you also want to assess for symptoms of post-dairy consumption. Symptoms of post-dairy consumption could include stomach pain, stomach irritation, diarrhea, gas, just a bunch of things that your stomach is not agreeing with due to the absorption of lactose, which your body is intolerant to. Cancer of the colon. So, what is colon cancer? Colon cancer is a cancer of the large intestine, which is the colorectal cancer. Some risk factors include family history, a high-fat, low-fiber diet, smoking, and alcohol consumption. All risk factors for colon cancer. Also, high eating a lot of red meat, low intake of vegetables and fruits. All of these things could lead to colon cancer if done, way too much or not eating these things enough. Some pathophysiology of the colon cancers include tumors that may be polypod or annular. Annular. Tumors that may be polypoid. Tumors may be polypoid or annular, causing obstruction. Most tumors are adenocarcinomas arising from adenomous polyps. Signs and symptoms. Early signs include weight loss, mild GI symptoms. Later signs include bowel obstruction, bloody stool, ribbon-like stools, abdominal distension, and pain. In order to treat colon cancer, first you gotta have it diagnosed by a colonoscopy, or a biopsy or a stool test. Treatment includes a surgical removal of the tumor, which is a colectomy or a hemacolectomy, and chemotherapy and radiation depending on the stage of the cancer. Some things to consider for nursing management is preoperative care, which is educating the patient on surgery and recovery, and post-operative care, which is monitoring for infection, pain management, stoma care if a colostomy is performed. Some health promotions in colon cancer. So to prevent colon cancer, which may or may not be possible depending on your lifestyle and family history and predisposing situations that put you at risk for colon cancer, a high fiber diet and a low fat diet could also help not lead to colon cancer. Regular screenings, which is a colonoscopy after the age of 45. Some aspirin, folic acid, and calcium may reduce polyp formation. So let's talk about colostomies. This is pretty much a surgical procedure that brings out a part of the colon to the abdominal surface to form a stoma. The purpose of a colostomy is to divert fecal matter when the lower part of the colon is not functional or needs rest. Some types of colostomy includes a transverse colostomy, which is a loop or double-barreled colostomy. And often, this type of colostomy is a temporary one. It allows for the future reversal. And then you have a single-barreled, which is an end colostomy. And this is one stoma, and these types of colostomies are permanent or temporary. Some colostomy locations include the ascending colostomy, and the type of stool that would be involved in this type of colostomy would be watery, unformed stool, which is usually temporary. That's because the ascending colon is going up, and the food is not fully digested. It's still absorbing some of the water and some of the nutrients. So it's going to be very watery right there. By the time we get to the transverse colostomy, this type of stool is more stalled, and you have a more unpredictable discharge. This is often temporary as well. Then you have the sigmoid, which is the descending colostomy, which is the most common form of the colostomies. This is a more solid stool. These are more predictable bowel movements. Next, we have the ileostomy. So what is an ileostomy? This is similar to a colonostomy, but it's in the ileum instead. Same purpose, which is to divert feces from the ileum. Some indications include chronic IBD, which is Crohn's disease, and ulcerative colitis, which we talked about earlier, and cancer and multiple polyps. Some stool consistency includes liquid digestive enzymes present, and skincare is essential because it's going to be like some of that acid that's leaking from the ileum can irritate the skin, so you're definitely going to want to assess for any type of skin breakdown with the ileostomy. There are 3 types of ileostomies. You have the traditional ileostomy, which requires a collection pouch. You have the continent ileostomy, which requires a cock pouch. Then a cock pouch is when the patient empties using a catheter and does not require a pouch. Okay, so I don't know why they call it a cock pouch, but hey. For preoperative nursing care, bowel prep, clear liquids, laxative, possible enema. For a nasogastric tube, which is the NG tubes, used to remove stomach contents before surgery. And antibiotics may be prescribed. And this is some preoperative care before the ileostomy is performed. Postoperative, you want to assess the vital signs, assess the surgical site, assess for bowel sounds, make sure that the GI tract is starting to move again. Assess for pain management and intake and output tracking. Monitor for ileus, which is paralysis of bowel may occur. We don't want that. Ostomy management. So for the colostomies, you'd want to enter when the bag is 1/3 full. Irrigation for the sigmoid colostomy to regulate movements. For the ileostomy, you'd want to empty this 5 to 8 times per day. You also watch for skin breakdowns due to the enzymes in the stool that could irritate the skin. Peristomal skin care includes cleanliness and protection. Those are the main purposes of it. The importance is that fecal matter must not come into contact with the skin. If it does, it can irritate the skin, cause more infections. Odor control. Avoid gas-causing foods such as onions and beans and some of the other foods we mentioned earlier, such as the cabbage family and stuff like that. And when you empty the pouch, it's called burping the pouch because it's gas inside the pouch, and when you open it up, there's a foul smell that comes out just as if you were farting, passing gas or flatulence or something like that. Pretty much is burping the pouch. If you've ever emptied an ileostomy before, you know exactly what I mean. Some psychological considerations for the ileostomies and colostomies would be body image. A person needs to adjust to this ostomy that is now on their body because they now have a bag hanging out of their stomach, and that can be very difficult for some people to get adjusted to. For support, you want to discuss with peers who have adapted to living with an ostomy. This could be very beneficial to them because it lets them know that they're not the only one experiencing what they are experiencing. Some evaluation and patient education. So goals would be to understand ostomy care, learn to manage diet and prevent complications, such as skin breakdown and electrolyte imbalance. Some psychological adjustments to changes in the body image. And that is pretty much the presentation of the lower gastrointestinal system and some of the disorders that are involved with the lower gastrointestinal system. I hope that you guys were able to learn some of the causes of these diseases, some of the signs and symptoms, and how to manage some of these diseases. Now, I just gave like a very quick overview of all of that stuff. You go way deeper into all of these disease processes because they all do have a lot more deeper processes, and some of the causes and things and some of the treatments I was not able to mention just for the purposes of this presentation. But if you like, definitely look more into some of these diseases, and if you're not a nursing student, if you are, I'd recommend read your Surg book. But if you're not, there's also plenty of other information out there that goes deeper into all of these disease processes. But like I said, this was my overview of the lower gastrointestinal system and some of the diseases and disorders that are involved there. Here is a list of my social medias where y'all can find me. Come follow your boy where I will be posting more content. Make sure y'all like and subscribe, and I will check back in when I have another presentation for you guys. Next time we'll probably be discussing the upper GI tract or whatever else I'm about to be going over in my Surg class. I have a test on this stuff on Thursday, so definitely wanted to make sure that I came over here and discussed this now because it's a form of my studying. So yeah, everybody have a great day, and yes, Nurse Jean, we out.